Well, it's nice that I'm the last talk for this session because I think we just all have a primary goal is to improve women's health and reproductive access care. And so here at Stanford, we have program that the main goal is to utilize education and train trainers locally with the goal of decreasing maternal mortality and morbidity in different with different approaches. So with that say, I'm gonna go here. Is that where I'm gonna go? So I have no disclosure. So what I would like to talk to you guys today is trying to put in context in these few minutes what it means to do global health and what it means to do global health for maternal health and maternal mortality. What is the current state of maternal mortality, which I'm going to just breeze through because I think we have been talking a lot about it this afternoon. How we can use obstetrical simulation in medical care and education. Discuss the possibility of interventions, what interventions we can use to decrease the maternal mortality, and also understand the challenges to trying to do that in local areas outside the states. And also, how do you like to be involved? What opportunities are out there? So when we look at global health, there's many definitions. From those, one that I really spoke to me is what it means to do global health. And it's an area of study, it's an area of research, it's an area that prioritizes to look at global health around the world, to really take a priority improving the access to care, health improvement, and for everybody in the world, people-wise. And I wanted to start this talk with this very nice say from this woman in Tanzania, where she just happened to be pregnant. That's all that she has. She's not sick. She's just full of hopes, and that's all that she has. But at the same time, it's sort of like a death sentence. So she's going to go to the sea to fetch a baby. The journey is going to be dangerous, and she knows it, and she might not come back. So just to put in numbers, every day this happens, one in about 130 women die for this just because they want to have a baby or they just, happen to be pregnant. Really, for complications of pregnancy or childbirth. We went over the definitions, so I'm not going to spend a lot of time on that. I just want to touch a little bit on what do we know since 2015 from the report of the WHO, where we can see that over 300,000 women die a year for pregnancy complication or childbirth. For what it is really sizable. But what is the worst part is that the vast majority of this is preventable causes. And that's where medical care intervention, we can really make a difference. Here to the corner, I wanted just to show a little bit. There is a nationwide in the United States, there's about 9 maternity consortiums that got together to put this report together. And this is just data in the state itself, but it's showing the same. I hate when nothing works. So about 60 to 70% of the causes are preventable here in the state as well. The causes are different because it's a developed country, but it's still causes that we can really prevent. Just to show you a little bit of a heat map, I said, you guys, we've been talking a lot about this, just putting in perspective numbers. I think we all becoming very familiar with these numbers. High numbers of maternity, it's expressed in ratios of 100,000 live births. So we see as high as at 239 and as low as 12 per 100,000 live births. When you can see in this heat map, the red areas, as we talk about, is Central America, South America, Haiti, and then looking at Africa and South Africa. Just to put in rough number, and I think Dr. Goldthwait took more about this, you could see how the disparity is there. Just to look at the highest mortality rate in the world is in Sierra Leone, where you can see it's about over 1,300 per 1,000 live births, as compared with Finland, that is only 3.8. And then when you look at United States, we actually have a very interesting case going on right now, because United States is the only developed country that is actually has a tendency now to have an increased maternity mortality. And it's becoming an epidemic to understand why here in the States our maternal mortality is increasing. And there's a lot of debate right now, and you have seen it in the news and reports, that it's not safe to have a baby in the United States. And the causes are many. We definitely have an epidemic of obesity. We have an epidemic of comorbidities with high blood pressures and diabetes. So a lot of that could be related, but I think there's more to this epidemic than just comorbidities. But when you look at the data for United States itself, it's very state dependent. And what is interesting is like also race dependent. So if you look at African Americans, they're the highest mortality rate that we have. As you can see, 42.8 as compared to a Caucasian that would be 13 only. So there is that health disparity that we have seen and observing too. So why our moms are dying? The vast majority of our moms die are for hemorrhage, but they're also for hypertension disorders, preeclampsia, eclampsia. We have what do we talk about? Unsafe abortion as well. We also, that Dr. Shah explained very well, we have the problem with sepsis, proactive labor distortions, and also depending on the country, we'll see also the influence of malaria and the influence of HIV. So just touching a little bit in what Kate was talking about of the Sustainable Development Goals for the UN. These goals specifically that come home for us, for OBGYN, it was nice to see that they really want to have this target that reduce less than 70 per 1,000 as a projected goal by 2030. And also to look at it, that they put in an emphasis on universal access and they prioritize in family planning, which is very neat. And looking, trying to integrate education system and make sure that this becomes like national strategies, and also to have being able to bring it all the way to the level of policies to create programs around the whole nationwide. So according to this Millennium report, we have made some progress, but not so much as I would like. So it's definitely cornerstone that we utilize education in able to disseminate information and create a way to have a safe birth, if you think about it. So if we can capacitate our healthcare providers, our birth assistants, our community service, and being able to, not only to be able to support a woman in labor and having a baby, but also to be able to determine this need high labor care and being able to transfer the patient out or reach out for other type of help, that also will be preventing maternal mortality. So it's definitely education is a cornerstone for us. So how do we learn? So the whole idea is like how we learn. So we learn with journals, we learn with textbooks. In medicine, we learn, you see one, you do one, you teach one. These days we have the internet, so we use internet, excuse me. But you have to put this in context globally. Is that really happening? Is globally, do we have access? And also, what about language barrier? Let's just use Central America, for example, where we have extensive experience. So yeah, they have the ability to get the journals, but can they read the journals? Yeah, they can get on the internet in some areas in Latin America, but can they understand the language? So there is that culture barrier too. So it's very important to know that we need to overcome those logistics areas too. So here, we would like to propose that we can use education, thank you, obstetric simulation, to trying to fulfill this gap and trying to utilize this cutting edge approach in medicine to improve medical care and to improve education. So what simulation it is really just reacting for example, an obstetrical emergency. So assign role players and do a drill of an emergency, postpartum bleed, shoulder distortion, an obstetric emergency, assign different roles and rehearse the emergency. So by the time that you really have the emergency, you have been there, you have a close feedback, you understand what are the protocols, and you understand how to carry with correct communication the emergency. Here in this picture, I'd like to show Dr. Daniels, that is our director of Obstetric Simulation Center here at Stanford, but also a pioneer in the field. working with some of the residents in Guatemala. One of the patients is our nurse, pretending that she's had a birth and is having postpartum hemorrhage, and how dynamic is the whole OB simulation happening together. So with that, I would like to introduce our program that is a global obstetric, global outreach, mobile obstetric medical simulation and gynecology surgery that we've been implementing here at Stanford. It's been going on for a few years now, and we are able to reach at different parts in the world. We had gone to Nicaragua, Costa Rica, Guatemala. Now we've been invited to go in the winter of 2022 India, and we're planning to go to South America as well. And because the emergency that's happening locally here in the U.S., now we have created Go Mom USA. So Dr. Daniels is initiating the going to the Mississippi and do a multi-hospital collaboration, bringing the mobile obstetric laboratory there and deploying the team there. So specifically, this is the region that we have been working for them lately, and we have been successfully starting a very strong collaboration. So we got Guatemala, Costa Rica, Nicaragua, we cannot go anymore. As you saw from our keynote speaker, it's impossible to access in Nicaragua, unfortunately. And I also wanted to acknowledge how Go Mom has been assembled. It was the leadership of Dr. K. Daniels, and also have the support from one of the associate directors on the Center of Simulation, Julie Arafet. That's one of the nurses that does all these OB simulations in Stanford. Dr. Amy and OBGYN faculty, residents, and students from Stanford University and from Kaiser Permanente. So here are just some pictures to show you how we approach this. So the idea is sustainability. The idea is to be able to have this cutting-edge education, hands-on, showing videos, lecture, interaction with clinical scenarios to the people, and we deploy ourselves locally to the people that are there every day, they're in and they're out. We use the approach to train the trainer with the idea that we don't have to be there in a routine basis. They can do this. We can deploy our knowledge. Yeah. So I guess I don't use it. I guess it's too loud. So in general, what we do is we have this this approach to get trainers. And what we want is to make sure locally we're able to captivate those people that are going to be able to, from generation down, train and develop this program. So that will be sustainable, and it will be respectable if we exist, if we visit or not. And use telemedicine to sort of have a continuation and have a system of check-in every 6 months to a year to see how things are going. So that's our ultimate goal. And here in these pictures, I wanted you to show you, for instance, in Guatemala, we were over 6 hospitals. Some of the hospitals are dependent on the Ministry of Health, and some of the hospitals are more like dependent on Social Security Service. So the training is a little different because the resources are different, a little different, but at the same, they're all some part of the same academic program for residency in OBGYN. We also have a collaboration going with San Jose, Costa Rica, and the University of San Andres. Last year, we were able to train over 100 trainees and about 80 nurses, because the system in Costa Rica is a little different than Guatemala. It's decentralized. So people come to San Jose, that is the city, but then they go outside the city and practice. And a lot of these local resources, clinics, maternity, is heavy representation in nursing. So we're able to also access the nurses and be able to practice firsthand these different drills of simulations and lectures. So the University of San Andres actually having now they're creating a center of simulation that we are helping them to develop. So they have a little more resources than Guatemala. So what we did, what we taught. So as we talk about it, the maternity mortality is significant for preventable sources. So the number one is postpartum hemorrhage. So we definitely were able to integrate that in our curriculum. That's one of the first drills that we do, how to manage a postpartum hemorrhage. So one of the things that we taught is how to do a surgical intervention in a way that you preserve the uterus and preserve the maternal life. And that's called the B-Lynch. And as you can see in this picture, it's very rudimentary. We use local materials, and we're teaching them how to suture the uterus in a way that it will compress the uterus down, it will stop the bleeding, and that will save mom. And it will solve future reproductions too. We talk about how to use misoprostol in the period of postpartum hemorrhage. And we also taught them how to do what we call the intrauterine tamponade. And for that, it's actually based on data that have been published from Bangladesh, where you can really just need a Foley. It's a catheter that goes in the bladder. You can use that, and it's very cheap and common in low resources areas. A condom and a suture. And with that, you can insufflate it all the way to 500 cc's if it's needed. And I had a study that was published, over 241 patients, 234 were able to save their life and uterus. So it's been very well taken there. And one of the beauty of this exporting these labs and taking the OB simulation is that you could utilize materials that are ready available for them. So they don't have to spend $2,000 trying to get a Bakri balloon like we have here. We actually can create one locally and very cheap and effective. So what other drills we do? We do shoulder distortion, and I introduce maneuvers that they weren't even aware of. So we bring our own pelvis, we bring our own babies, and as you can see, we all gloves, and we practice maneuvers. And so introduce the regular maneuvers, but we also introduce new maneuvers, sort of like a minor rotations, and deliver the posterior arm. And for preeclampsia, we also do lectures and interaction simulations for preeclampsia and eclampsia. How to identify, how to prevent it, how to manage it. So specifically, in Guatemala, we had not only have a wonderful relationship, bi-directional, it's also a very interesting place to be able to have the GOMONS program, because it's the highest mortality rate in Latin America. So for us, it's like super important to be and have a presence there. Here you can see there's like 4 babies all sitting together, and you're hoping that they're not going to get mixed, but it's very common to see that. And in the next slide is one of the small centers that we go 3 hours away from Guatemala City, where we're trying to teach maternal CPR, because they have so many deaths. This is one of the areas that they see deaths all the time. And actually, the day that we were teaching them how to do CPR, one mom died. So it's really something that should be rare, and it's not a rare event. And one of the things that they struggle is with the concept that we introduce of after 4 minutes of doing maternal resuscitation in somebody that already have a uterus at the level of the umbilical, the next step is to evacuate the uterus. They really struggle with that. All their moms die with the baby inside. So if they are constant, just talking about cultures and how to be able to combine our approaches to their approaches, this was definitely something that caused a lot of difficulties to really process it. So we tend to go to this big maternity, one of the hospitals that has up to 17,000 deliveries. And we observe too. We're also learning from them. It's a bi-directional learning that they actually, because they are so tight on time and they're so overcrowded, they need to get people delivered. So they give it about 12 hours. And if you haven't have a baby, you're going to have a C-section. They don't use high dose of Pitocin. They just use barely 10 unit, which is very minimal. And they just follow their labor. If they don't advance, they go for a C-section. This is just a labor place where you can see mom is laboring there. They expect that somebody have babies before should have a baby within 40 minutes pushing. And they also expect that somebody that never had a baby before within an hour having a baby. If that fails, they're going for a C-section. They don't use instrumental delivery. The vacuum doesn't exist in Guatemala. Forces exist, but they don't feel comfortable using it, so they're not utilized. So I said, you can imagine the cesarean reaction is very high. They have a common maneuver that's using fundal pressure, trying to push the baby down when mom is pushing. That for the most part is okay, but if you're having a shoulder dystocia, that's the worst thing that you can do. So we see those different approaches that sometimes are not the best way to go. The same for episiotomy, like everybody that has never had a baby gets an episiotomy. With the thought that that would prevent some kind of tear of 4th degree. Here's the OR, and this is where they do the C-sections, and they have about 40% of the C-section rate. One of the things that are interesting to see is that they don't have the same amount of infection that we maybe can see when people labor longer. So they have less amount of infections, but definitely higher rate of C-section. So with this amazing collaboration that we have, and we have established all this ability to bring the mobile and educate and do the program that train the trainers, we also feel that there's an opportunity for research here and to understand how we can impact with the unit, the global health of this country. But this is our medical records, so it's a little challenge to do research in this setting, but we have a wonderful partner, that is Dr. Herrarte. He's the director of all the residency programs in Guatemala, and he actually represents for ECOC, the Latin America postgraduate. So he actually, for the Latin America, he's the representative too, and he's definitely been one of the most advocate persons for us. So he sent us one time an email that is very touching, where he's really thanking us because he had to do a Lynch, and this woman, he tried, it worked, she saved her uterus and saved her life. But what it was more impactful is that 2 years before, he didn't know this, and the sister of his patient died. So he's really been a supporter of the program, but he himself has seen changes. So through that collaboration, we now have started a pipeline with our medical students. We have about a couple medical students going there for the med scholar. One of the ideas is to allow them to be deploy their therapy there and being immersed in what it means to be in the medical field there and advance our research. One of our students, this is just to show the poster that she just presented and it was awarded, Pamela Mesa, where she actually spent 4 weeks in Guatemala, was able to have the experience and to be in labor and delivery, to go through all those charts that I just showed you, and look at the impact of simulation since we got there and trainees and providers. And she looked at 6 months after intervention, and she found definitely that they were practicing and had improved the maternal care. So now we're going to have another way to continue doing this educational tool, but also improving medical care and have the ability to look at it. The other important part is that it's a bidirectional, so we also want to bring in residents here and spend time with us as a way to have this nice collaboration. So just as a way to finish, and we always have to, and I think some people in the audience had asked very important questions. We need to think about the ethical consideration. We need to think what is the best way to help. And so we should be able to understand the community, the culture, our own bias, intrinsic bias, and how we can be there to endorse the culture and help the community and not impose ourselves. We should be able to have sustainability and being able to live our mission, and that mission continue and definitely making different outcomes. So for that we have to be very culture sensitive and understand, and very unselfish, I would say. So just to close, how do you guys can involve? Well, I think Lisa touched a little bit about the medical tourism. There's a lot of initiative, and for example, there's organizations that do surgery and go and do wonderful surgery, but they don't have a way to follow up. So there's no way to have knowing what happened with complications or how patients are going to care after the surgery. So those are things that can be a little bit also on the flip coin of doing global health. So the idea is to have a sustainable program that is immersed in the local community and is run by the local community. So more like you were saying, being a consultant and say, need assessment, how we can help, how we can provide the expertise, but you're running the program. ECOs offer experience. You can use the health volunteers overseas, or you can go to ECOC in Malawi, or you can also look at us in the website, Go Mom, Go Far. We're inclusive. We take voluntaries. Everything that we do in Go Mom is voluntary. I want to close with this because I think it's important that you understand our department of OBGYN is totally committed. So our vision is to be a local but a global leader. We want to advance and transform the field of women, the women's health through the lifespan. And we have this mission that we want to improve women's health through innovation, compassion care, education, advocacy, and discovery. And so it's very important that we endorse that we need to have trainees. We need to train people for the future. We need to be able to have our future leaders to be able to understand the needs of women's health and make it better. Here's just a picture of our medical team from Guatemala, but also all the volunteers. We had nurses, MA, medical students, undergrad, residents, and doctors, fully trained OBGYNs, volunteering the time doing this. So just a little quote from Doctors Without Borders, the fight for women's health, because it's tomorrow needs her. And I just want to do a special thanks to Dr. Daniels that couldn't be here, but she was so nice to share her slides. I will take questions.